Thank you. Because of time, we will go directly to our fourth speaker, Dr. Kersten.
So I would like to share with you some of the treatment options for patients with relapsed disease, and mostly discuss with you some of the drugs that were already mentioned by Jorge and that were already discussed during the meeting the last few days. So what should you do when the disease recurs? Well, as you've already heard, hopefully we will be moving away from chemotherapy and go towards targeted therapy, either with new antibodies or with more advanced targeted drugs, that most of them can also be used orally, which is of course a big advantage to patients. So what should you do when the disease recurs? Well, actually, if you have no signs or symptoms and it's just an increase in your IgM level, we advise again to wait and see, because it's not necessary and it's not beneficial if you start the treatment again early. And again, it's not one size fits all. You always have to look at what was the response to the prior treatment, because if you had a response which lasted for like 4 or 5 years and you tolerated the treatment well, it's very feasible to give that same treatment again. We look at age, we look at comorbidities, we also look at the bone marrow reserve, and of course it's important, do you need rapid disease control? Again, is there hyperviscosity or other serious problems? And we look at side effects, for example, neuropathy. So, as Jorge's mentioned, a study done in the United States concerning which lines of treatment were used, and a similar study was recently performed also in Europe, and it was done by Christian Buske. It was sort of a retrospective survey of patients treated for Waldenström's in several countries. And also here you can see that they looked at the different types of treatment. Monotherapy, it could be monotherapy, for example, with chlorambucil or other chemotherapy drugs. Combination therapy with antibody and combination therapy without antibody. And these were patients treated from 2010 onwards. And surprisingly, there were still a lot of patients who did not receive treatment with antibody, with Rituximab. And I think it's very important that that this is demonstrated, so that we can make sure that patients across the world, also in Europe, get the right treatment. So I think these real-world data are really important. And which is why in your bags you see the whimsical leaflet. I would advise you all to read it. There's a plan from an Australian hospital to start a sort of a registry that can be filled out by patients themselves, so that we can have the data as perceived by the patients. I think it's a very good project. We're discussing also with Hematon how we can implement this also in the Netherlands. So what about new treatment options? Well, there's new antibodies. I'll discuss them with you. They can be directed at other proteins that are expressed on the tumor cells. There's antibody drug conjugates, and there's a way to use the patient's own T cells, and this was already mentioned by Guy before. It's a way to train your own immune system to recognize and kill the tumor cells. But what's also important is that the Waldenström cells in the bone marrow interact with the microenvironment, and there are several ways in which you can target this interaction, and by targeting the interaction with the microenvironment, you can also make the cells less strong and easier to kill. And as you understood from Zachary Hunter's talk, we all the time understand better what goes wrong in the cells. We actually don't know why it goes wrong, but we do know what goes wrong, and we can influence that. So most of you are familiar with antibody treatment, such as Rituximab. Actually, antibody treatment targets a protein on the tumor cell. In this case, Rituximab targets the CD20 antibody. And when the antibody interacts with the CD20 antigen, the patient's immune cells will kill the cells, make them disappear. There are several ways in which we can improve the current antibodies. We can, there are several second generation CD20 antibodies. There's not much evidence yet that they work better in patients with Waldenstrom's, but there's not much, not many studies have been done with that yet. We can target other antigens on the cell, such as CD38. I'll tell a little bit about that. And also something which is called immune checkpoints, which are sort of a brake on the immune system. So I'll get back to that in a minute. So tell you a little bit about what proteins are expressed on the Waldenstrom cells. Actually, Waldenstrom cells are sort of an immune cell themselves, and they are derived from the stem cells in the bone marrow. And this is just depicting what happens in the bone marrow. Cells get more mature. You start with a stem cell, it gets more mature, and ultimately it becomes a plasma cell. And the Waldenstrom cell is actually somewhere in the middle between an activated B cell and a plasma cell. It has the CD20 antigen on the cell surface, but it also has often has CD38 on the surface, and that's also an antigen, a protein which can be targeted. Another protein that's expressed on the Waldenstrom cells and which is important for the support by the microenvironment is the CD27 antigen. And CD27 interacts with CD70, which is derived from the microenvironment, and you can try to block that interaction, which is also a way to make the Waldenstrom cells feel less at home in the bone marrow and have them killed easier also with other drugs. So what about CD38? CD38 is an antigen which is expressed, as I said, on a large proportion of Waldenstrom cells, but also on myeloma cells. And as you know, multiple myeloma is also a bone marrow disease. And for multiple myeloma, an antibody has been developed. Actually, development for that started in Utrecht in the Netherlands. Monique's hospital was involved in the development of that drug very much. And it's an antibody called Rituximab. And it has direct anti-myeloma effects, but it also has other effects on the immune microenvironment. And several studies are now starting also with Rituximab in patients with Waldenstrom's. Not many data are available yet. So what's the story with activating your own immune system? Well, as a matter of fact, we've known for a long time that the patient's immune cells, which are called T cells, can actually recognize and attack the tumor cells. But somehow there's sort of a brake on the immune system. And actually, the year 2013, cancer immunotherapy was the breakthrough of the year, and it became very interesting because, for example, for patients with melanoma and renal cell cancer for whom there were no treatment options, we've seen very dramatic responses using these checkpoint inhibitors. And how does it work? I'll try to explain. So, of course, you have an immune system which helps you to defend yourselves against all kinds of viruses and bacteria and other attacks from outside your cells. And normally you have an activation of your immune system, but if that would go on and on, you would be yourself attacked by the immune system. So there has to be some point at which the infection is over and your immune system has to stop responding, otherwise you will have autoimmune disease. So this is done in part by these molecules which are called PD-1 and PD-L1. So your T cells will have PD-1 and your tumor cells have PD-L1. And because of the interaction between PD-1 and PD-L1, it makes it very hard for the T cells to recognize the tumor cells. So this is sort of a defense mechanism which is used also by the tumor cells to stop the T cells from attacking them. And because we now have antibodies that can actually block this interaction, so it's an antibody against either PD-1 or PD-L1, these antibodies can actually take the brake off the immune system and thus can cause responses against the tumor. So there's other ways of achieving this, and that's called bispecific antibodies. So as I said, antibodies are important to kill tumor cells. So they're directed, for example, against CD20, Rituximab, but there's also an antigen called CD19. And CD19 is expressed on all the lymphoma cells, also, by the way, on normal B cells. So you can make an antibody against CD19, which can, in some cases, kill the CD19 positive cells. But if you combine that capacity of this CD19 antibody with an antibody that recognizes the T cells, so it's sort of done in the lab, you make a combination of a CD19 and a CD3 antibody. CD3 is on the T cells. What you can do, the T cells have CD3, the tumor cells have CD19. By using this antibody, you take the T cells directly to the tumor cells, and you bring them into direct contact. And what happens then is that the T cell directly can kill the tumor cell. So you take the T cells in the body of the patient, and you redirect them to the tumor cells. And the cool part about it is that these T cells, once they've done their job, they can just go and take the next tumor cell out. So it's a very interesting sort of a new treatment, which is now being given to patients with acute leukemia and aggressive lymphoma. I haven't seen any data yet in patients with Waldenstrom's macroglobulinemia, but it's one of the ways that you can really arm the immune system to kill the tumor. It does have some side effects with you, because you can imagine if you activate all these T cells in the body that you can also have some fever and other responses to that. And then there's another way that you can do that, and that's by making the T cells actually specific for the tumor cells. And that's what they call CAR T cells. And CAR in this case stands for chimeric antigen receptor, and I'll try to explain what happens. So basically what you will do is you take T cells from a patient and you make them specific for the tumor cells. In this case, it's mostly again CD19, and CD19 is present on all types of lymphoma and leukemia. And actually you take the antibody and you put that in the T cell, and you make the T cells specific for the CD19 positive tumor cells. And basically what you do is you need a vector, you need a virus to get this construct into the T cells. The T cells will then express this new receptor on their surface, and in that way they become specific for the lymphoma cells, and they can get rid of them. So it sounds complicated, but it is complicated sort of treatment, because it's like a living drug. What you do is that basically that you isolate T cells from the patients. You do this by a pheresis, a white blood cell pheresis. These cells are then cultured in the lab, and they're infected with this virus. And this virus, it can be sort of a HIV-like virus. That may sound scary, but it's a virus that has been devoid of any possibility to replicate, so it's a safe procedure. And when the virus is inside the cells will express these CARs. They're then expanded and cultured, and of course lots of quality checks are done. It takes a few weeks, and then you can give the cells back to the patients. And in the meantime, you give a sort of a mild chemotherapy to the patients to make the cells make the chance better that the cells can persist in the patient. So this is a rather new and I think very promising treatment, which might replace for some part the role of stem cell transplantation with donor stem cells. But a lot more work needs to be done. We're doing a clinical trial at the AMC right now, and for the first patients now the cells have been collected, and they will be reinfused in patients within the next few weeks. So, although it's very promising, it's also quite toxic treatment because, as I said, you have these activated T cells. They come into the body of the patient, they recognize the tumor cells, and they start to proliferate. It's a living drug. And these patients can have high fever, but also low blood pressure and respiratory problems. They sometimes also have neurologic problems. And as I said, CD19 is not only on the tumor cells, it's also on your normal B cells. So you will have to some degree, also depletion of the normal B cells. So there's a lot more to be found out about this toxicity, and we're trying, there's better ways of dealing with that all the time, but it needs a lot of work. So basically what is being worked on is that it would be great if you have these cells and you could sort of switch them off when you no longer need them, or when the side effects become too severe. So going back to the biology lesson that Zach gave you earlier this morning, hopefully you remember all of it. So I would like to go back to that a little bit, because there's a difference between how normal cells proliferate and how tumor cells proliferate. So normal cells, and as I said, Waldenström cells are actually sort of immune cells themselves. They only grow or proliferate when it's necessary. So your leukocytes or your lymphocytes will only divide when there's a signal from outside that says there's an infection, you should go and proliferate. And you need a signal for that. And once the infection is over, the cells will stop with the proliferation. So if you have a mutation in one of these lymphocytes, usually what happens is that the cell will notice something's wrong, and then you will have this programmed cell death. The cells will decide I'll stop living, and the cell will die. But if you have more than one mutation, and you heard about the MYD88 mutation, most cells have more mutations than only just that one, then there's a loss of this growth inhibition, and all the cells will start dividing, and you will have a tumor. And as we understand better what exactly causes these dysregulated signals, we can try to influence them better. Well, this is sort of a simplified schema of which signals are important for a cell to proliferate. So I'll take you through that slowly. No, I won't do that. Because this is for a hematologist. I'm a doctor, I'm not a biologist. It's like being in the subway in Tokyo. And the Dutch patients have seen this before, but it actually struck me when I looked at the map, because it really looks like a cell. This is the cell membrane and the nucleus, and you see all these pathways going through. Luckily, when you're in Tokyo, there's English subtitles, so it's actually, Monique and I were there, we managed not to get lost. But it's better if you can sort of simplify it. And if you look at the situation in Amsterdam, it's actually much simpler, because we don't even have this line yet. So it's really easy. You should focus on the main signaling pathways and try to somehow in tumor cells try to block the main pathways, like the central station. And the central station, as you heard before from Zach, is NF-kappa-B. NF-kappa-B activation is really important in tumor cells for proliferation and also for the inhibition of cell death. So if you look at the major pathways in lymphoma cells, you heard about BTK and about MYD88. We do have several inhibitors of these pathways already available in the clinic. And you've heard about ibrutinib. I'll show a little bit more about that. You've heard about proteasome inhibitors, which are really downstream in this pathway. There's inhibitors of PI3 kinase called idelalisib, which is also a very effective drug, but we found out that it's also a very toxic drug, because it gives a lot of problems with diarrhea and pneumonitis. And there's other agents which are really more tumor cell specific. So you've heard about the Ixazomib trial at Dana-Farber. We have a similar trial also in the Netherlands, and we do that together with Belgian centers and Greece. And we give this in combination with dexamethasone and Rituximab, and we give the patients 2 years of Rituximab maintenance, and this trial is ongoing. So what about ibrutinib? You've heard about it quite a lot, I believe. The phase 2 study was done by Dr. Trion with 2 other centers in the US. 63 patients participated, and about 90% of the patients responded. So you do see a very rapid decrease in the IgM levels and a very rapid increase in the hemoglobin levels. So patients feel better very rapidly. You do see only a modest effect on the bone marrow infiltration. So if you do a repeat bone marrow biopsy, you will still see infiltration with lymphoplasmacytic cells. And if you interrupt the treatment for whatever reason, even 3 years, for example, on treatment, the IgM levels go up again very quickly as well. So you have to sort of continue treatment. And at this meeting, the long-term follow-up results were shown by Dr. Leah Palombo from Sloan Kettering, who did the trial together with Steve Trion. And with her permission, I show you some of the results. So there's a sort of a definition issue with the progression-free survival or the event-free survival. Event-free survival, also patients were counted that had transformation to a more aggressive type of lymphoma. But in any case, after 3 years, still about more than 70% of the patients were in remission. But there were some progressions, and there were also some cases of transformation to aggressive lymphoma. But as you can see, most of the patients are still alive, thank God, after several years. So out of the 63 patients, 25 patients had stopped the treatment, and in 11 cases that was because of progression. There were a few new side effects with longer follow-up, and a very detailed analysis was done of the patients who showed progression, and in 3 out of 6 patients who were tested, it was shown that they had new mutations that were not there when they started treatment with ibrutinib, that were involved in the BTK gene or downstream of that. So somehow the Waldenstrom cells are so smart that they can, become resistant to targeted treatments like this. So there are several new kids on the block. There are actually 3 other BTK inhibitors in clinical trials. There's acalabrutinib, and several patients here in the Netherlands also participated in that study. It's the side effect profile and the efficacy seem rather similar. And there's also 2 other drugs also in clinical trials. And I think importantly, we are also starting combinations of treatment in the hope of preventing resistance and having deeper remissions. And as alluded to by Jorge, it's also possible to target this pathway, for example, by making IRAC kinases or agents that target the MyD88 assembly. So another possibility actually is not to look so much at proliferation and MyD88, but try to get the cells to die quicker. And for cells to be able to die, the BCL2 gene is very important, and this was already mentioned also by Zach. And there's a BCL2 inhibitor which is called venetoclax, which we have a lot of experience with in patients with chronic lymphocytic leukemia. But also in the trials that were done, there were a few patients with Waldenstrom's, macroglobulinemia, and most of these patients actually responded to treatment. As mentioned by Jorge, there will be a phase 2 clinical trial in patients with Waldenstrom's. Of course, also for new drugs like this, it's also important to define the toxicity and ways to handle it. Because actually when the first patients with CLL were treated, it appeared to be quite a dangerous drug because it was so effective that the first patients who were treated with it had tumor lysis syndrome. And of course we see tumor lysis as a good thing. It means the cells respond to treatment. But if they respond too quickly and you don't take any measures to prevent that, then it can be very dangerous. Patients can have renal failure, and actually some of the first patients treated with this new drug died because of that. So a whole system was made with what we call a ramp-up treatment. Patients start with a really low dose, and then if that goes well, the next week they can increase the dose, and again and again. And you take all kinds of measures to prevent this tumor lysis syndrome. And this is the trial mentioned by Jorge with venetoclax in patients with Waldenström's. And also in this trial, the dose will be increased gradually. So finally, what is the role of stem cell transplantation? I know this is also, this question often comes up, and it was a big debate also during the meeting this week, actually yesterday. You can do a stem cell transplantation either with your own stem cells or with the stem cells from a donor. I think we all agreed during the meeting that there's only a very small percentage of patients that are actually candidates for stem cell transplantation. Because an autologous stem cell transplantation, although it can give long remissions, it's not a curative approach, and it also has a lot of side effects and also increases the risk of secondary malignancies. And an allogeneic stem cell transplantation, where you use the stem cells of a donor, gives the risk of severe infections, but also something called graft versus host disease, which is also something which carries a high risk of transplant-related mortality. So only a small group of very young patients who have not very good responses to the regular immunochemotherapy and the newer BTK inhibitors, they might be candidate for a stem cell transplant. And because, of course, of the age, the median age at which Waldenström's occurs, most patients are not really candidates for the stem cell transplantation. So in conclusion, I think there's lots of new and hopeful developments, but it's crucial that we have more knowledge of how the disease arises and what we can do to more specifically target it. And it was already stressed by Jorge, it's really important for patients to participate in clinical trials, but also to collect the samples and try to do biologic site studies, and that's why we bother you so often with questions on whether or not you want to participate in the biobank. The biobanks are implemented in several countries. So also in the Netherlands there's possibilities to participate in clinical trials with the Ixazomib and also with one of the newer second generation BTK inhibitors. The trial will start very soon. And I would stress again, we can have a war on cancer and a cancer moonshot program, and we can, put lots of money in it. But I think the true progress can only be made if we have better collaboration and collaboration across several countries and without any boundaries, with sharing of the data, also by the patients and the doctors. And making really an effort together to get further into the field. We really need collaboration also with the patient organizations. So I'd like to thank you for your attention and thank you for being here.